All right. So back on our pain scale, I received a few questions on it, so I just want to address it as we tie it into Oxycontin. So the way that it works, and has worked for a while, is that if you state your pain on a certain level on that scale, and then the provider does not respond with an opioid prescription, and you receive your patient satisfaction survey, and you denoted, I did not feel as though my pain was adequately dealt with, that would affect both their patient standing, and the hospital would, and the provider would not necessarily be reimbursed for your care. So we tie prescribing of opioids to pain scale to a financial incentive. And anything you tie to a financial incentive is often going to be successful. And similarly, those patient satisfaction surveys are what help a hospital become, like the different stars they receive, the top 40 best hospitals in the USA today, like those are based on the number of providers that they have in part on that provider history and that provider rating scale. Similarly, providers do not often want to fall into remediation because it means someone has to follow them around the hospital all day and sign off on anything they do, which is not a fun experience for anyone. So the reason that it became an issue was that if we'd sort of been prescribing what had been out on the market at that time, which was oxycodone and Vicodin, Dilaudid, Lorazepam, and all those other things that we still hear about, but Tylenol 12s and other less addictive medications, we might not nearly have ended up where we are. We still would have a problem, but the introduction of Oxycontin is really what changed the game. It is a unique drug, and it had a $200 million marketing campaign in 2001. It was one of the largest marketing campaigns for a medication at that time especially. And what they released was a drug that had two different unique components that they swore by. One, it is the only drug to have been labeled abuse-resistant. That is the direct quote off the label. And that was stating that the medication had gone through a study that indicated that patients who were opioid naive, that means you had never been previously prescribed an opioid, in a hospital-based setting, were prescribed the drug for 7 days. At the end of 7 days, the patients in the study did not show signs of withdrawal, and therefore, the drug was labeled abuse-resistant. That does not sound like a quality caliber study. It's because you could not pass any IRB or chair of a department or get a degree with that type of research. Similarly, the peer reviewing of those studies did not occur. So that's how we sort of check things in the scientific world. The second piece was that it was going to be a miracle drug because it lasted 12 hours. So all other drugs at the time lasted 6 to 8, like Tylenol or Aleve. You know that whole commercial, it's like 8 Advil, 12 Tylenol, or just 2 Aleve. It was that same strategy, that why take more when you can just take 1 Oxycontin for 12 hours. Again, hospital-based setting, opioid-naive patients were dosed. Over 83% of individuals in that study had breakthrough pain at 6 to 8 hours, but were not given a second Oxycontin. They were given acetaminophen or something else. And so at the end of the study, they said that nobody received more than 1 Oxycontin in a 12-hour period, and therefore it was a 12-hour dose. Again, not an accurate study or depiction of what occurred. Other data was proven to have been falsified. They eventually were charged with fraud, and there was a class action lawsuit that indicated that they had falsified data and charting material. And so those are some of the factors that played into this. There have been significant investigative reports on this topic. 60 Minutes have been running stories on it. This is not sort of new news, but it's important to know about how those different statements around the medication have played into our prescribing or our belief that it was safe or abuse resistant. So those factors have obviously played in, but there's other things that people will say regularly. I took an opioid and I didn't have any signs or symptoms. I took it for the prescribed 7 days, I stopped it, and I moved on with my life. And that's good because we're all different, right? Some people can look at a cupcake and put on 10 pounds, and other people can eat them every day for every meal, right? We all have different genetics, and that shouldn't be surprising to us, right? But when it comes to substance use, we're very quick to say, well, if it didn't happen to me, it shouldn't happen to you. We know that our genes play a role. How much of a role? We still don't know. The lead genome researcher in the world would not be insulted by my statement on that. We know about 40 to 60% of your genetics play in. For example, we know that alcoholism may run in families specifically through men. There's something there that's altered in the genetic compound. Our environment plays a role. So peer pressure, the earlier exposure to a drug. So this is something we need to be very aware of when it comes to neonatal abstinence syndrome. If those infants are exposed at the earliest stage, what does that mean for future dependency on a smaller low dose? Because they've already had that exposure. And then we know that trauma plays a monumental role. 70% of people with substance use disorders have a trauma history. So if we just treat a substance use disorder, that is why we have recurring relapses as well, because we've not treated that underlying cause and that initial reduction in dopamine. We also know, or I mentioned this about NAS, that it's something that is occurring. I'll just briefly give you the definition, is that it's prenatal exposure to drugs that are discontinued suddenly at birth cause NAS, and it's any substance that can pass through the placenta. So tobacco can cause neonatal abstinence symptoms. Gabapentin or Neurontin is one of the most severe withdrawals that we see in infants. They have severe arching and other medical conditions. And infants may respond differently based on mom's genetics. Neurontin is the drug that is often most commonly given in our region. It's Neurontin/gabapentin. One's the pharmaceutical name for nerve pain. So it's most commonly given out for nerve pain. In our region, the street name for it is candy, because it's easy to get like candy. Just about anyone can get Neurontin. There is no medical test to denote nerve pain that most providers would go through, and so unfortunately if you go in and say, having some nerve pain, especially if you have diabetes, then it's often a hand-in-hand. It increases the effect of other opioids as well when taken in conjunction.
Yes. So can you get high on it alone?
You have to take an awful lot, but yes. Have I seen a patient high on Neurontin? Yes, I have. But you need to really be taking a lot of it. Unfortunately, you might see some of that behavior in our residential programs, where they've lost access to other drugs, but still not treating, may not have satisfaction, like reached the point where they're not compulsively taking something, that sort of soothing process, and so we've seen folks on a Neurontin.
Can that be detected on a drug test?
The level, virtually impossible to be able to tell. You would just be able to tell you should not be on Neurontin, gabapentin, but yes, you can test for Neurontin or gabapentin. Not in like a typical 13 panel over the counter, or not one that you're not sending off. Yeah, full toxology would need to happen. It's actually one of the drugs that helped Cabell Huntington Hospital spur their own toxology program, because we were sick and tired of telling them it's gabapentin. Like the baby is withdrawing off gabapentin. And so they would just talk to mom and often get, she'd admit, having used that drug, or being prescribed it. Lots of people are still prescribed it throughout pregnancy. It's something that the medical field is working to educate on.
Is that because, depending on where the child is, there are some people that have legitimate pain, depending on where
Absolutely.
that child is settled in the, like sciatic nerve pain, that kind of stuff, So.
Yeah, and I think it's very important. None of this advocates the idea that we should swing against or away from medications, right? There is a just place for people with chronic pain, people with chronic illnesses. We just happen to know that opioids might not actually be an effective treatment for chronic pain. Research out there indicates that there is more effective medications for chronic pain than Oxycontin or other opioids. It's actually a combination, and I have some info on that if you were interested. But for infants, it's really important to be aware of what the drug that they might have been exposed to could be, whether it was prescribed or not. And so having those conversations with folks, obviously anytime we don't encourage any of our patients to discontinue a drug or medication without talking to their doctor. Yeah.
Very quickly, if a expectant mother is prescribed and is taking Neurontin, that's the only thing she's taking, does it have adverse effects on the infant? If so, what treatment is there?
It's completely patient determined. What we have seen is that there's already certain factors like mom's metabolism rate. Some women metabolize drugs very rapidly, and the infant the fetus at the time has no exposure. It doesn't give it long enough to pass through. And so we see that with medication-assisted treatment. Some moms are metabolizing that so quickly that when the infant is born, there's no signs of withdrawal. Other people, exact same dose, exact same amount of time, the infant goes through withdrawal. And so those individual factors are what we're seeing as playing a role. I believe the medical field is moving away from any prescribed Neurontin or gabapentin during delivery because it has been enough rates of adverse consequences at withdrawal symptoms at delivery.
If there is adverse effects on the infant when it's born due to the Neurontin, what treatment?
So there would be a medical protocol that's put in place that...
Can you guys hear his question? His first question was if a mother has been prescribed this, does the child always have the withdrawal symptoms? And of course her answer was no, and you heard hers. And then his second question was, how is the infant treated if they are experiencing the side effects of this Neurontin? And just so you guys understand, as a layperson, when someone tells me they're on nerve pills, I think they're on like antidepressants. You know, I don't think of actual like sciatic nerve, medication. So you may be told that this person's on nerve pills and you may think it's an antidepressant and you might need to do a little bit more digging into exactly what type of nerve they're talking about. So, I mean, that's just my experience with what that's called.
Yeah, what people refer to, like the colloquialisms around drugs, it can be very confusing. It's very hard to stay up on that. Now, the treatment of any abstinence syndrome, so that does not matter what the drug is. People can have abstinence syndrome off caffeine. If mom was, drinking, for example, a lot of those Monster drinks or the really high caffeinated things, infants will show withdrawal of that. Now, withdrawal treatment is based off of the score the infant receives in the hospital, which is a chart that has different things that an infant might show. For example, sneezing. Infants who have not, at delivery, infants should not sneeze. It's not something babies do. So a lot of people don't know that. So moms just say, well, he's just sneezing. Well, you shouldn't be sneezing. That actually is a score of 2 automatically on the charting of the infant to identify where medication should be placed. So normally if an infant is below a score of 8, there is no medication-assisted treatment provided to that infant upon withdrawal. What that medication is varies depending on the drug or substance that mom was using and the level of symptomology. As symptoms increase, the amount and duration of medication is different. So an infant might be prescribed a drug that they taper off of over a period of a month. Some infants, it's 2 months. Others, 5 days. So it really comes down to the severity of symptoms. The amount of information we can get honestly from mom especially is beneficial. When did you use, what did you use, and how much of it did you use? And that's why if we can reduce stigma and get mom to be honest, we can actually have a much better picture of what is going on with that infant far quicker than a toxology, cord blood, or any of those other tests are going to provide.
And if they're being treated, is that the entire time in the hospital?
So treatment varies based on state and location and provider's knowledge. Current evidence-based practice is moving in some ways away from pharmacological interventions. So there is some research. Kentucky has a program like this. Massachusetts has a program like this that focus predominantly on the relationship between the mother and the baby at the time of delivery and can prove in those cases, in certain cases, that reduces the experience of the infant's withdrawals faster than pharmacological treatment. The type of drugs has also been changed in some of those programs. And what that can look like in a community might be, in some areas, it's just those infants are in the NICU, the neonatal intensive care unit. CABL, it's the NTU, the neonatal treatment unit, and that's a specific place that doesn't have all the beeping and blurping and the noises of the NICU. It's 3 babies to a room, and they can be held, and there's not as many cords. It's very low light. It's incredibly quiet, and there's one nurse for those 3 babies at all times. So they're checking their dosing and monitoring their progress over that period of occasion. And then, for example, in Huntington, we also have Lily's Place, and that's an NTU that's out in the community, basically. And so it's a medical center, but based in the community, that can allow some more visiting for mom, and they're working on some programs like rooming in, which is moving towards those other models that have been very successful at reducing infant symptomology and withdrawals. Yes?
Yes, to go back to a couple of slides, maybe you did elaborate on it, but maybe I missed it, but increased risk factors, biology at birth account for 40 to 60% of a person's risk. Could you elaborate on that? Like what kind of genes?
Did you guys hear his question?
Yeah, I was going to repeat it. Yeah. So the question was about what is sort of that biology, those genes, and how that might account for. I would love to elaborate on it, but we know very little. So basically what that is saying is that there is certain genetic profiles that it indicates that an individual might be more predisposed. Now, anytime we're talking about a genome, you're talking about a predisposure to a risk, not a guaranteed risk, right? It's very rare that we know that a single gene, once turned on, causes something. Where we know that that occurs in some cases is, for example, the BRCA gene, right? We know that certain women with high risk factors, a history of breast cancer before the age of 40, and BRCA A or B, have a very high likelihood of developing breast cancer. Now, it took us a very long time to determine that because you needed a large enough pool of people, and then we needed the ability to go in and look at a gene. To do genetic testing around this topic, you actually need to know what you're looking for before you can go in and look for it, right? I can't just sequence your genome and then be like, oh, that's what that gene does. I have to sequence your genome so many times with so many different people and then say, it appears as though when this is turned on at this stage by this neurotransmitter, that something occurs, is much more likely to occur. So we're looking at things like, if mom has this genetic marker, is the baby born with that same genetic marker? Across all of these moms at Cabell Huntington, for example, that is a study we're working on, where we do genetic swabbing for moms. In other cases, is it this gene turns on this factor at this time, and that seems to lead to some of these factors. So if you saw the genetic map that we've done out of the moms that we've had, you just cry. Like I look at it and I'm like, I don't know what this means. It's like the world's largest word web with teeny tiny numbers that are like H1042, H1042.1. And so it's very unclear, but we do know that your genetic factors account for about 40 to 60% of your risk when it comes to the likelihood of developing substance use.
Thank you.
All right. We'll keep going. I'm just briefly going to touch on this. Hopefully it's something you know something about. If not, the best way to figure out about adverse childhood experiences is a TED Talk by Nadia Burke-Harris. And if you Google the word TED and ACEs, you'll be there. It's the only thing that comes up. It's a brilliant video. She also wrote a book. And she was just appointed the Surgeon General of California, or the medical director, something. She just got a huge, and it's awesome because they're really going to take an in-depth focus on ACEs. So ACEs are these 10 different factors that increase an individual's likelihood of negative consequences. So 3 factors of abuse, emotional, physical, sexual, 2 factors of neglect, emotional and physical, and then 5 what they consider household, violence towards the mother, household substance use, household mental illness, incarceration of a loved one, and parental separation of divorce. As you take the ACE scale yourself, you get a 1 for each of those. So you could have a 0 or a 10.
Referring back to what was spoken of before you got here, and,
Yep.
okay. So when we're taking a child out of the home for whatever reason, that's been involving with like the separation and divorce would be also another factor like that.
So if a child is removed from the home, they automatically have ACEs because any of the factors that would cause removal are going to be emotional and physical sexual abuse or neglect, and or violence or substance use. And so knowing if a kid has been removed, they have an automatic ACE score. And my likelihood would be that they have an ACE score of at least 4 or more.
But so does the actual removal increase that score?
It depends. So it is not considered one of the factors because of the population that this was initially explored in, which was over 17,000 people. The frequency of certain factors were not as highly correlated as these 10. So parental separation could be considered something that occurs in that moment, but it's then how it's managed or handled. For example, divorce does not automatically make bad kids, right? Like divorce, and I as a couple therapist all the time, should we just stay together? No. In some cases, staying together and in a highly disrupted household is far worse than an amicable separation. It's how you do the process, right? Suing each other for 18 years following a divorce is highly damaging to children. That is an exact case I've had. So, was that damaging? Yes. Should they have been together? Probably no. Is the kid gonna have ACEs? Definitely. And so, what other protective factors can you put in place? A high ACE score can be mediated by protective factors, right? We can intervene on a high ACE score. A positive role model. Programs like Big Brothers, Big Sisters grow out of programs like ACEs. We need to have a role model with that child who helps them engage. A healthy adult who tells them, you know, you're worth it and you can do this. A good teacher, right? Teachers are one of our largest barriers to the onslaught of ACEs that our community will face. So what we know is ACEs are very common, and lots of people have high ACE scores with no negative consequences. Other people, low ACE scores, very high negative consequences. Again, it's a correlation, not a causation. High ACE does not equal bad life. And so we know that lots of people deal with it. However, an ACE score of 4 or more makes someone 12 times more likely to commit suicide. Okay, that's higher than major depressive disorder. An ACE score of 6 or more is 20 years less life expectancy. So our ACEs are associated with these negative consequences of both behavior, physical, and mental health. ACE score in drug use, you can see that an ACE score of 5 or more appears to be an important threshold around substance use, because ever having a problem, becoming addicted, and advancing to IV drug use is correlated, again, with an ACE score of 5 or more. So if we are seeing ACEs and doing nothing about them, we are going to continue to see these rates rise. And unfortunately, ACEs are those adverse childhood experiences, but they're also adverse community experiences. And that's when I, off the top, said, this isn't an opioid epidemic, this is a trauma epidemic. Our adverse community experiences are those things down there at the bottom. And you can see that those are factors that exist that help create this perfect storm within our region. Poverty, discrimination, community disruption, lack of opportunity, poor quality housing or affordability, and violence. Those things in a community help breed unhealthy roots that cause the unhealthy tree of ACEs. And so it's a lot of different things, but it means there's multiple points of entry into the system and multiple places that we can change. Briefly, I'm not going to talk about mental health, but I've brought it up a few times, and so just to know, mental health and substance use disorder are highly, again, correlated, not causated, and so it's important to be aware of that overlap, because we don't just want to treat substance use and not mental health, and the other way around. So normally when we are out in the community, people say, well, who's doing something about this? The doctors must be treating this, right? In many cases, yes, we have done vast education. We've released a lot of help on this. But unfortunately, 94% fail to diagnose the early signs and symptoms of substance use disorder. And a large majority of folks report they didn't ask about it because they don't know what to do if the answer is yes. And so something we introduced in Cabell County was a program like SBIRT, Screening, Brief Intervention, and Referral to Treatment. We trained 5,000 people over 3 years all over the state of West Virginia in that program. And what then we identified was that RT part became an issue. You've screened, you've briefly intervened, and you've moved them towards what treatment? And so making sure that we had that treatment in the community became another primary focus. And that's some of what helped spur this ongoing need and needs assessment for the programs we have in Cabell County, and we're working to set up around the state. What we currently do for the majority of folks is, unfortunately, the Incarceration detoxification program, which just means we put people in jail. And so that is the most common form of intervention for an individual with a substance use disorder, is once they're engaged in the legal system. Unfortunately, 60 to 80% of individuals with people who have substance use disorders commit a crime related to their substance use disorder following release. And over 95% of people, of drug abusing prisoners, return to drug abuse following release. Why? Because there is very few, if basically none, evidence-based programs within our incarceration system. And so if individuals are incarcerated, they have a substance use disorder, we are not treating the substance use disorder, and so they are either A, continuing to use while incarcerated, or B, returning to use immediately upon discharge. I'm going to take that one first.
Do you know if there's any data being tracked for how the substance abuse that's going on incarcerated? I mean, we know it's pervasive because people show up to sentencings high as a kite.
Right.
Do you know if anyone's tracking that data? Because it's, I mean, honestly, they're not detoxing in jail often.
Right. Yeah, that's why I say this is what we think. Like, go to jail and detox, and they should.
Joke.
There is in some states. I don't have the data, so I don't want to speak to it right now. There's been a greater push for engaging the judicial system as a whole in conversations around this. The question was, do I have data, or do we know data about how many people continue to use while incarcerated? A lot of folks with substance use disorders will be very honest depending on how you ask the question, right? So I can tell you 10 ways right now to get drugs in jail. Never been to jail, thankfully, but it's very easy, like literally 10 ways right now. So that clients have told me that I would never detect it. And they're always coming up with new ones, so we know a large majority. Now, there have been some large-scale sort of examination of this. The difficulty in any research around a prison population is that they are considered a classified vulnerable population. So you cannot conduct certain research, or you need a very high level of oversight to conduct the research because it's a population that you could be taking advantage of. So they dispute how to study that.
I think the bigger fight we're going to have is when administrators recognize that it's a failing of their own to keep their COs and persons from bringing this crap in, so they're going to be resistant to gathering the data.
Very true, yes. The system as a whole would rather say, he said that one of the issues is administrators and sort of that oversight saying that COs or other people may be bringing drugs into the prison system, which we have had at least 4 reported cases of in the past 6 months, where people have overdosed or guards have overdosed, and then it's like, how did the drugs get there, right? We just did that investigation. They're like, we have no idea how it entered the airway system, right? How is that possible? So, you know, those types of things do become one of the barriers to exploring that research. Yes?
In addition to that, the information is not only is incarceration not detoxification, but in many cases, people who didn't use drugs are now exposed to drugs.
Yes.
Come out
Yes.
of using drugs.
Yep. So the point was said that it's not only that people are not detoxing while incarcerated, but that in fact some people who did not go in using drugs leave using drugs. We know that individuals may go in and it can be highly traumatic, right? If you have not ever been in that situation, it's pretty terrifying. Like, that's why they do programs like Scared Straight, lock people up. And they did that show where they locked like journal or people up in prison, see how long they'd last, and they didn't do very well. It's not a condition that most people like, right? We don't want it to be, you know, the Ritz-Carlton. But that unfortunately it can be a traumatic experience for someone, and then someone says, look, the only way to get through this is to take this. Okay, right? I don't know what I do in that situation, but I can definitely tell you my anxiety would be through the roof. So that would be a piece. The other unfortunate fact is a lot of people go in to be incarcerated. They make what are not necessarily considered a highly supportive and healthy relationship with those fellow members of their pod. And when they leave, they have this newfound community of non-healthy relationships. And the community that they've been discharged into hates them. They can't get housing, they can't get a car, they can't get insurance, they can't get food stamps, they don't have custody, all of these other factors. And so then we drop them back into that. What else are they going to do but use substances or go back to finding one way to make money? It is a vicious cycle. There are absolutely issues with people who commit crimes, and we need to be dealing with that. It's not suddenly that everyone's scot-free and there shouldn't be any consequences. But when is our system not effectively obtaining the results that we would like, which is people to stop using substances and reduce crimes? And we know that treatment can do those things. States that have introduced medication-assisted treatment in the prison system have seen decreased rates of incarceration and recidivism. So if we're looking at those as close to us as Ohio, well, close unless it's snowing, but states like Ohio, those areas have shown success in types of models like that. There is work on a pilot program in West Virginia. It was announced over 18 months ago, so we're waiting to sort of see what that would look like within our incarceration system. All right, so a few just touch points on what we can do. Okay. All right, cool. So No single treatment for these components is going necessarily to be appropriate. And so there's a lot of different factors that come into play. What works for one person is not going to work for another, and that's why substance use is very difficult to treat. We just said, well, why can't we just find the magic bullet? Why can't this work? And we unfortunately know that we are dealing with, by definition, a chronic, relapsing brain disease. Chronic relapsing does not mean one time you're done. It unfortunately means high rates of relapse and recurrence of the symptomology. That's actually one of the terms we're moving towards, is talking about a recurrence of symptoms. So you have a very brief window to engage someone who is motivated to engage in treatment. I'll give you our quick response team, for example. They go out in Huntington. It's an EMS provider, a law enforcement provider, and a mental health or recovery coach provider. And they go out to the location of an overdose within 24 to 72 hours. And they attempt to engage with the individual who was struggling with a substance use disorder and who overdosed. And what we have seen is incredibly high success in a program like that. We have large numbers of people immediately engaging in treatment from that first initial 15-minute visit. And that group then works to place them in different places around the state. We've also struggled to engage people in the ERs. If you overdose and you are transported to a hospital, they medically detox you, and that is it. That is the treatment that is provided. And so at that point, you would be in the throes of addiction or the throes of withdrawal, and we haven't treated it. We've just medically got you over what is sort of the worst flu of your life. So when we discharge you in the community, people do what? They go back to using, because now they're not in a high, and they probably go back to using the same batch that caused that fatal overdose, which is why you see a recurrence of people 3 times in one day overdosing. Why? Same drug batch 3 times, about how much someone's going to buy in the morning, and so you'll see that relapse or return. So identifying what needs to be treated for that individual is highly important, and what other barriers or factors may be playing a role into that. Lisa, I want to check with you on time. When do you? Okay. Oh, okay. Cool. We can keep asking questions then. All right, so this is what we consider the continuum of care. And this is our density and spectrum of services. So to have a healthy community and to treat this as a whole, these are the types of services that every community should have access to. That does not mean every community needs all of these, but it does need to be accessible to them. So what does that look like? Health promotion and prevention. A healthy community, a wellness sort of plan, having wellness incorporated in the community, dealing with those underlying ACEs, right? That roots of our tree are what we talked about in that first step. Early intervention, whether that's access through syringe exchanges or harm reduction programs. For example, our harm reduction program in Capital County at our health department, individuals come in, they're required to meet with a peer coach. And out of the first group of folks that we were piloting that type of model through, he had over 60% of people, after a period of time that they built a relationship with him, be referred into treatment, and is working on those follow-ups. So through that initial connection, we are drawing someone out of the shadows, and they are going to engage with a health professional. A program like SBIRT, Screening, Brief Intervention, Referral to Treatment, SBIRT, is something that classifies that early intervention. Community-based. We need things that are just accessible to our community. That might be 12 steps. There's evidence-based 12-step programs. Those are called SMART recovery. MAT 12-step facilitation, also an evidence-based program. You need programs like the Loved Ones Group, or GRASP. Loved Ones is a program for family members of someone struggling with a substance use disorder. And GRASP is Grief Recovery After a Substance Abuse Passing, GRASP. So for family members who've lost someone to a substance abuse, right? Again, the acronyms, I know. So all those types of things, celebrating families, positive parenting, things that our church and our faith community can engage in. Our outpatient services, what those look like, I'm going to touch on a few of those. Residential services, that ability for someone who is not able to thrive in their current environment, they may need to go to a residential program, right? We know a lot of folks can be treated successfully out in the community, but other folks cannot exist when you are dealing with all of those other barriers to successfully completing a program, like I don't have reliable transportation, I'm in a domestic violence situation. I do not have actual housing, right? We have folks who regularly, one of the classifications for coming in is they're homeless with kids because they left a domestic violence situation or a home in which a lot of substance use was occurring. And then hospitalization. What does that look like? And how can it be part of the continuum? The worst thing we can ever do is cause that detox to be its own island. Detox is deadly when it's an island. If you detox someone off of a drug, which we now call withdrawal management, because you're not detoxing, so that's just a weird thing that we like to throw around. Withdrawal management, if that occurs and an individual does not then go into some type of treatment, they have a higher likelihood of a fatal overdose. Why? Because you medically withdrew them off a drug, they have gone through a physically fragile state, and then you have released them with no skills, right? So what are they going to do? Go use substances, because that's all they've done for the 2 days prior to the 48 hours they spent in withdrawal. And so making sure that that is part of a continuum and never offered in isolation is a key component of this. So, yes?
How do you determine how long a period of treatment someone needs, or how do the institution determine?
I will acknowledge that question on each of the slides about the type of treatment. Cool? Okay. So she asked about how long someone might need treatment. A very common and important question, and I'll mention how we've come to the standards we currently have and how we might want to decide that in the future. So one of the things I just want to point out is that when we're treating substance use disorders, you are treating, like I said, chronic relapsing brain disease. That chronic disease, there's 4 in the United States that we really examine. Substance use disorders, type 1 diabetes, hypertension, and asthma. Type 1 diabetes, hypertension, and asthma were considered to be 3 of the largest, quote-unquote, medical drains on our system, right? People who have a condition that can be managed that unfortunately have relapses or recurrences of their symptomology, right? We don't say people on diabetes relapse. We don't say people with asthma relapse. We say recurrence of symptoms. So we're talking about a medical model. We're talking about recurrence. And if you look at this, you can see that substance use disorders fall right in the mix. That hypertension, asthma have actually higher rates of recurrences of symptomology, and that substance use disorders fall just above and within the range of type 1 diabetes. And so one of the things that we just need to acknowledge is that a recurrence of symptomology is not always a failure. In some cases, it's a point to re-examine what worked or what didn't work. We also know that, and if you just quit smoking, I apologize, but it takes people on average 7 or 8 times to quit smoking. Okay, so 7 or 8 times people try. If that's the average, for those of you who are around that number, I apologize. An average means that there's a whole group way above and a whole group below, right? So some people, I know folks, smoke for years, went, I'm done, and quit, never looked back, right? I know other folks who tried and tried and tried and tried and tried different methods. Well, one of the things that we actually want to look at is that 7 times isn't actually that bad, right? I know that all of you kept all of your New Year's resolutions this year, right? I mean, it's only January 30th, so it's only been 30 days. I know that all those things you set on the magical night of midnight, you're still doing, right? Chugging right along. Everyone's still like, what, gym 4 days a week, right amount of water consumption. Like, I haven't drank water in a week, so I mean, right? So those things, we don't all manage to keep goals we set to, right? Sometimes we have a recurrence, right? Folks who quit smoking and don't go out and drink for a while, but then go out to the bar with their friends and everyone goes outside to smoke and they're like, oh shoot, I quit smoking, right? Or I only smoke when I drive, right? They get in their car, they light up, darn it, I quit smoking. So those types of things, that's a recurrence, but you learn something, right? Maybe I can't go out with my friends for a little while. Maybe I need to quit smoking when the polar vortex arrives because it's very hard to go outside right now, right? How do you set yourself up for success? And so talking about that with someone who's dealing with a substance use disorder is part of this. What are you doing that's going to make you successful? I can stay with my current relationship. He's just a drug dealer. It'll be fine. Right? I don't mean to say that you can't do it. I'm not judging your willpower, but like, I can do it. I don't think that's going to be successful, right? If you're trying to quit drinking, working in a bar might not work. I have a friend who totally does. Sober, works in a bar. Okay. But it's not going to be my standard of treatment for most of the people I'm working with. So, treatment duration. What does this look like for different people? People regularly ask me, well, how long till they're cured? Hate to break it to you. We don't really think there's a cure to addiction. Because if there was, we would have done it. We would have fixed this, and we'd all just know how to withdraw caffeine and sugar and salt and substances. We wouldn't be dependent on those things. So the type of drug that's being used impacts our ability to how long treatment should last, right? The length and type of use, the potency, other co-occurring disorders, our mental health conditions, our support, and the availability of treatment all impact how long the treatment might need to last. So the research indicates the following. Outpatient and residential treatment less than 90 days is associated with limited to zero effectiveness. 28-day programs came about because that is exactly the number of days the insurance provider would provide for the first person who went into treatment. 28 days, totally arbitrary number. No evidence, no research. There's no person who came along and was like, how long should this be? Let's look at this, let's examine it. 28 days it is. Nope, they literally were like 29 days we're not paying for it. Right, 28 days it is. Right, that's how that number came into our society. So 90 days. This should be obvious because if you've ever tried to quit something, you can make it a month, maybe 2 months, and then those things start to reoccur, right? It's not very simple. If you did not make your New Year's resolution, it's because, well, you've made it 30 days, you're clear for it. You don't have to worry about it for the rest of the year, right? No, it's something that just because you've made a certain period of time doesn't mean you continue working on. Medication-assisted treatment, less than 12 months, is again associated with limited effectiveness. Why? Because it takes a period of time for an individual to withdraw off the substance and to rebalance their dopamine. Okay? So dopamine levels do not naturally just come back. And our research indicates for some folks, they may never. It may be very true that some individuals need to be on a medication-assisted treatment program for the rest of their lives to reduce the likelihood of them having a recurrence of their symptoms or a fatal overdose. That's what we're trying to stop, a fatal overdose and existing competently in society. That's what we kind of classify around recovery. And so that dopamine level in some folks, depending on the length of use, if you are depressed and so you already naturally produce lower dopamine, women and men, women are more likely to become addicted to an opioid on a lower dose. So we know that they're tracking on our hormones. And so those factors are going to impact someone's successful likelihood to achieve a great success in a medication or an outpatient program. I'll take that question first.
Do we have any citations to documents of studies that we can actually show a court that, so when the court says 28 days is probably going to be enough, we can say no. This study, and this study say otherwise.
Yes. All of them are currently produced by government. The drugabuse.gov houses a repository of this information. So anytime I'm presenting around anything that, well, I'm a researcher, but like citations are my favorite thing. No, they're horrible, I hate them. But I will always have a full document of citations. For these, I pull directly off drugabuse.gov because I'm not saying it, the feds are. So that's who has pulled together that compilation of information to make that a suggestion. No problem. And I'm happy to give you all the boring citations that you have to feed through, but they cite it all there on theirs and have footnotes is the easiest way they do it on their product. Question right there.
Yes, for the medication-assisted treatment, are those drugs that are used for that, do they not affect the dopamine cycle or the dopamine system?
One sec. Let me see if I have the picture. Okay. I will specifically address the drugs in that on a slide where I can show you how they do that or how they don't. Because yes and no, depending on what you're on. So what we do know, and if you talk to someone in recovery, they will say recovery is take a day at a time. If they say that, there's definitely 12 steps. But those are language that has permeated our culture. It's a day at a time. Every day is a chance for recovery, and every day is a chance for recurrence. And so protecting one's recovery is incredibly important as they progress through different life changes. Someone might be doing very well, and then an important anniversary comes up, and they struggle, right? We all go through seasons of good times and not so good times, where we might sleep well and then not sleep well, right? Those factors are going to impact someone's recovery, but it just means that they have another higher risk factor they need to look out for. So what does realistic expectations mean? Well, we want to make sure that recovery is personalized. When I talk about all pathways to recovery, It means that, for example, Project Hope for Women and Children allows people on abstinence-based programs, i.e. they're not taking any type of medication, and we have clients on methadone, we have clients on Suboxone, we have clients on Sedentrex, we have clients across that spectrum. It can happen. The building did not burn down when we allowed those 4 people to sit in the same space, which is one of those myths often perpetuated around conversations of recovery. It also helps us address stigma because no one knows what anyone's on. It's not any of their business unless they want to share that. It is that take it a day at a time, and each individual is going to define what they mean by I'm an individual in long-term recovery. Once you say I'm an individual in long-term recovery, that's personalized. That does not mean like everybody suddenly says that at 9 months. Everybody suddenly says that at 1 year. Some people say it very quickly. Other people, no, I am struggling and continuing to struggle with this. I normally get a question around this, so I'll just address it, is what about 12 steps in AA and the use of like, I'm an addict, hi, I'm so-and-so, and I'm an alcoholic, or hi, I'm so-and-so, and I'm an addict? We talk a lot, and not from sort of an outsider ivory tower perspective. There's a group called Faces and Voices of Recovery. That's a national organization that is local chapters that abbreviate it by calling it FAVOR, F-A-V-O-R, Faces and Voices of Recovery. And they really work within the 12-step groups to be aware and acknowledge stigma, and saying that, if part of your recovery is to own it, one of the steps is to take accountability. If that's part of your recovery, that's okay, but being aware of how that language reflects in the larger community. So I work with one of my coworkers will say, I'm an individual in long-term recovery, and he says on Fridays when he goes to 12 steps, he says, hi, my name is, and I'm an addict. And so that switched because of how we need to control that more social narrative. The second is that a lot of people, one of their biggest issues within the 12-step community is that lifelong definition that you're this thing that society hates. And so there have been a large push to encourage other types of language within that sort of movement, which is totally allowed. And so we allow the Faces and Voices of Recovery in that network to engage in that conversation more than we're going to tell anyone what they should or should not say about themselves. So what does recovery potentially look like? Well, what I'm doing at any given time is trying to increase the amount of time between use, right? So that does not mean that I'm saying like someone should get in recovery and we'll carry them through the lifespan. How do we increase the duration between the likelihood of use? How do we set them up for success every day? Similarly, if I can't get them into recovery, what can I do to reduce their harm, right? I need to reduce the likelihood first that they're going to die. That is someone's child, mother, sister, brother, and no one wanted them dead. And we know that when an individual gets into recovery, they actually provide more to society than they would have had they never entered into substance use. So there's actually this overcompensation effect that they can do these, the finance people do that, not my expertise, of that cost analysis, how to do that, of saying, if an individual, this was their projected life, enter substance use, and that it actually goes up and it's higher after they engage in recovery. So I want to do that. I want to keep them alive because I have no idea what their future holds. I have no idea what that potential looks like for that person who does not look very good in that initial moment. I want to decrease the amount they're using and the way they're using. I want to introduce safe and clean syringes if they're using IV, because that's going to reduce their likelihood of infectious disease and mine. As a community, it's that herd mentality. We also want to increase the likelihood that they're engaging with another professional at some point, right? Are you talking to a healthcare provider? So the idea that someone who's intravenously using is walking into a building in daylight, it is lit up, and they talk to someone, a recovery coach and a nurse, that is moving on the pathway to recovery far more than people shooting up in a house down the street that we never get to see or hear about. And I want to make sure they have Narcan. Everybody and their mom should have Narcan in their day. So everybody should be carrying Narcan. I have Narcan on me at all times. I have it with me right now. So that is something that I make a concerted effort to always carry, and that we encourage everyone we're working with to do so. And we never know who's going to need it. We've had people administer Narcan in Cabell who administered it to a family member who literally just took too many. Like unfortunately this happens with people who might have memory loss, which can also be a byproduct of opioid use. And so they might take something, take it again, and then they took it later in the day, and it slowed their heart rate dramatically, which is that first sign of an overdose. And then how do we integrate recovery into our community? How do we create an environment that people can return to that is safe, healthy, and safe? So what do some of those look like? Well, I mentioned SBIRT, but I wanted to spell it out for you there. So that's a screening, brief intervention, and referral to treatment. That's considered the gold standard. SAMHSA has, by SAMHSA, that's who gets the gold star. Public health approaches, what does harm reduction look like? What can that include? Can that include Narcan or naloxone training, infectious disease testing, contraception, programs like VLAR, voluntary long-acting reversible contraception. That's a thing, it exists, it's a voluntary program, you can opt in. It would be wonderful if everyone was offered that at the time of delivery. And so when it was something that they would just be like, just so you know, there's a thing. And then they started making someone go in and talk to people in CABL and say, here, this is a program. It actually means that you have less to worry about after you're pregnant, whether they were someone with a substance use disorder or not. And so they were able to increase that program and that success. In most cases, it's paid for and free to individuals to engage in. So MAT, we could spend a lot of time on this, but I want to just highlight some of the key pieces. So that image is hopefully easy enough-ish to see. So what we're looking at there on the charts is that there's two major types of medication-assisted treatment. There's agonist, and that means the drug that the person takes actually goes into the receptor in the brain and activates certain opioid receptors. So it's a controlled type of thing that we're putting in there that tricks the opioid receptor, okay? And then you have antagonist drugs, and those are the types that go in and block the opioid receptor, but does not activate it, okay? So if you can see, I want to make sure, I can barely see it on my little thing. So I'll put it down here and make sure. So our first one, the first piece there, okay, so the first one on that chart is methadone. So that is methadone. Okay, so that drops in and it actually activates the receptor. So methadone goes in and it's an agonist and it activates that receptor right there. The second drug there is buprenorphine. Buprenorphine is the medical name, not the brand name, of Subutex. Subutex is only given to pregnant women because they cannot receive the combo, which is buprenorphine plus naloxone, those two, which causes the block. If the fetus is exposed to the Subutex, there's some very limited research, but it increases the likelihood of withdrawal while internally, because they would receive that naloxone blocker, which is going to blow off the opioid receptor and can cause that withdrawal. So pregnant women receive Subutex. That's the pill form. And then people post-pregnancy would switch back to Suboxone, or most people are on a Suboxone, and that's the strip. If you see it, it looks like a Listerine strip. It's sublingual, it goes under the tongue daily, and most folks are dosed in a 7-day period. They receive enough strips for 7 days, and that's part of that program. And so the reason those differ are the way that they are activating the brain. So methadone is actually activating those receptors, whereas Suboxone is not. It is blocking and tricking. So it's coming in as that antagonist type of receptor. So buprenorphine alone does not include that trick, the block. And so that's how those differ. And so buprenorphine and methadone trick the brain into thinking they're still getting the opioid, whereas naltrexone, the opioid full antagonist, blocks the effect. And so naltrexone is mixed in with the buprenorphine to create the Suboxone. So Suboxone is the mix. Now we have injectable Suboxone, that's the thing. There's also the pipe that looks like the injectable birth control. So those go in the arm, and so someone can receive that and it can stay in the system. These are actually advancing regularly. And then you have Vivitrol, and that is the injectable shot that someone receives once every 30 days. There's not as much research on Vivitrol because it's newer. Also, we find it very hard to engage people in the program. It takes about 7 days of sobriety to off a drug or medication to be engaged in a Vivitrol program. And if most folks can go 7 days, they might not need Vivitrol. So in those early stages, that's a piece that becomes a barrier. That's why Vivitrol is most commonly used in incarceration systems, because that person is allegedly off the drug and medication for 7 days. It also is incredibly painful. It's normally a medication dose is less than 2, this is where not a nurse. Like the small dose of an average is like 2 ml, the teeny tiny version, and it is over 3.5. So it takes a specific training to provide that shot, and it can be incredibly painful into someone's arm. And so again, adverse, it's another barrier because people talk about it, and then the rumor mill gets going really quick on it. And so those are the ways different types of drugs are engaged with someone. An effective medication-assisted treatment program is proven to improve patient survival, increase retention so that people stay engaged in the program, decrease illicit use, increase patients' ability to maintain employment, and then improve birth outcomes amongst women. So women who are on medication-assisted treatment programs are highly successful at having far lower rates of withdrawal or adverse consequences for those children upon birth. So those are some of those standards. This is all the information, again, I pulled directly from the Substance Abuse and Mental Health Administration of the federal government. These are exactly their points. And it is, as of right now, MAT is considered the gold standard for keeping someone alive and in recovery for the longest period of time. It shows the decreased use and recurrence of symptomology. What we know that the research says is it decreases relapse, that it's more effective at preventing infectious diseases or other types of things that someone's going to keep using, and that it prevents overdoses. And so, again, that's from drugabuse.gov, and so working with them and their research on this. They have lots of info and webinars all around this topic. And then, so the big myths, right? So these are the top 2. Methadone and buprenorphine do not substitute one addiction for another. When we are talking about an addictive behavior of an illicit opioid, we are talking about those 3 items: craving of the object of addiction, continued use despite adverse consequences. An individual who's currently using heroin is rarely able to maintain a job, right? They are not successfully engaging in most workplaces. They are often involved in the legal system. They are not maintaining healthy and effective parenting. Individuals on medication-assisted treatment do. They are walking amongst us all the time. You would never know that they exist and are all around us because they are maintaining their recovery. They are in the workplace. They are effective and healthy parents. And they continue to thrive and exist in that. And so the dosage of medication, again, does not have a high. These drugs have ceiling effects, which means there is a point in which they help, and then beyond that, you could eat like all of your Subutex in one day. You wouldn't do anything. You just then feel weird. So it's not going to cause an increased high to that effect. And then what it allows is that brain to heal while working towards recovery. Diversion of buprenorphine is actually very uncommon, especially in communities that reach a threshold of treating the problem they have. When communities talk about high diversion rates, it means they're diverting substances to people who need them in the community. And so what is happening is you have an unmet need, and so people are diverting to other people who need them, right? So no one's diverting Suboxone to me, right? Like, I don't go out, I'm not trying to buy Suboxone. I have plenty of people around me who are using it. They don't divert it to me because I don't need it. You divert Suboxone to someone who needs it. So when you can reach a threshold in a community where you actually have people being treated for the disease, then you have far less rates of diversion. In fact, you often can eliminate, in many cases, most of your diversion down to a single point. Again, we're diverting potentially a substance that is non-deadly and not going to kill anyone, versus when we're diverting heroin use. Yes. Okay. And you can.
But again, this is just for opioids, right? So somebody on Suboxone and naltrexone can go out and use MAP or benzodiazepines or those things, and the Suboxone has no effect on that.
Not necessarily. So it can cause severe sickness. So Suboxone and benzodiazepines is a potentially deadly combination. So we rarely want to have that, and it would not have the same effect. So that combination, we know, does not produce that same effect.
Same effect as to
High of yes, the potential high off of benzodiazepine or those sort of depressed. Benzos cause a weird sort of symptomology, and so it's not going to have that same receptor in the brain. It's being blocked by the opioid receptor, but also similar chemical structures to what you would find in other types of drugs or pharmaceuticals specifically. Now, methamphetamine and Suboxone is a growing area of trying to figure out exactly what occurs. Anecdotally, some people may continue to use meth, but it appears to dampen the effect. There's something triggering that is not allowing that full effect of sort of the rage or the that huge upper stimulation to occur. And I think it's, as a whole, some folks, one of the critiques of individuals on Suboxone is often similar to what you hear someone well controlled on a bipolar medication. You know, I no longer get that real high, and I don't get that low, but I kind of just feel okay. And so meth causes people to have that real high, and that seems to be dampened by it. But Suboxone is not a treatment for methamphetamine addiction, which is a thing. So people say you can't get addicted to meth, totally can't become addicted to meth. And so working on other types of treatment, unfortunately, it is easier, far easier to withdraw someone off methamphetamines, and course of treatment like residential, and creating a gap between the recurrence of use of methamphetamine does continue to be far more successful. So they're prime candidates often for residential, which we're seeing that increase rise of. All right. Okay. So outpatient treatment, what does that mean? Intensive outpatient treatment can include all day, every day, but you just don't stay there. Or it might just be those people who go to see a therapist once a week or once a month. Now, MAT treatment in conjunction should be assisted treatment. Medication prescribed by a physician, if we're talking about Suboxone or Subutex, once every 7 days they meet with their provider. Once a week, there should be group therapy for an hour. And then once a month, 1 hour of individual therapy. Some programs, for example, Valley Health, would use 2 30-minute individual sessions versus 1 hour. So that's going to be different depending on the program. Now, like I said, we have women in Project Hope for Women and Children who are on medication-assisted treatment. So they receive their therapy. Still, they have to check in with their provider. They get their dosing. They still see therapy in group with that agency who's prescribing. But they're then in a residential program. So they're getting 4 hours of group a day on therapeutic services, 2 hours of supportive group, and then they have constant contact with their therapist for at least 1 hour of additional intensive therapy weekly. And so when those overlap, you still have to meet those quote-unquote minimal standards. There's a lot of creative ways to engage MAT in the community, and what we need to be doing is increasing access so that primary care physicians can be seeing a patient for substance use, diabetes, hypertension, and asthma, all in the same waiting room, and we're just rotating them through like we would a normal client. That's going to be the most effective way to engage a population, especially in rural communities. Because we get some questions about it, and we've talked a lot about it around the state, PROACT is one of the programs that we've initiated. It has our 8 little balls there around it of all the different services that can be provided when someone comes in. And that's a partnership with Cabell, St. Mary's, Marshall Health Valley, and Thomas as the second location is going to be in Charleston. And so there will be one here in Charleston that will be a second PROACT where Thomas will take some of the lead that they're obviously not engaged in Huntington to the same degree. It means immediate access to all pathways, so there's medication-assisted treatment, spiritual care, therapy, individual outpatient group, and then job, training, education, employment, the whole gamut. So if it's something that might help that person engage in a pathway to recovery, then we have PROACT. One of the funniest things, or not funniest things, but one of the craziest things was sometimes, you know, you say if we build it, they will come idea. But we weren't necessarily sure. So PROACT opened, it's on 20th Street in Huntington. It's the old CVS building. The irony is not lost on us. It literally wasn't open. The door had been put on that morning, and the board of wood taken down because the door broke when it came for delivery. And an individual walked in, like literally like door puts on, woman walks in the program. We're like, no, wait. But as we said, one stop, we're going to promise to provide that commitment. She had her husband, or her boyfriend, had been incarcerated that morning. She had just lost custody of her children. She had just shut up and said out loud in a house just up from PROACT, I don't want to do this anymore. This isn't who I'm meant to be. This isn't my life. Someone in the house said, there's a new program down in the corner, you can just walk in there. How they knew that, I don't know. We've had no media or press really yet. And so she walked in and just said, I need help. We transported her to a medication-assisted treatment program that was like actually up and running. and was able to engage her in treatment. And for the next 3 weeks before we were officially open, every day the number just increased of people walking in the door saying, help me. It has been open since December, and we have over 300 patients, individual patient contacts with PROACT. Individual patients, not contact points. And so showing that programs, it's needed and that people actually want recovery. That's something we hear all the time. They don't want it. The QRT brings them over, the ER brings them over, but huge numbers of just self-referrals and walk in the front door, which is really nice to see, and it's very inspiring when you're there. We have the MARC program, that's the Maternal Addiction Recovery Center, and that is a program that supports pregnant women in Cabell Huntington Hospital engage on a medication-assisted treatment program from any time in their pregnancy to 6 weeks postpartum. And so they receive those services, including prenatal care, Subutex, individual group therapy, psychiatric, and then community connections to resources, including family navigation services. Question?
Yes, that PROACT thing sounds wonderful.
Yep.
I'm wondering how we're going to get that throughout the state. Is there any way you plan?
We're working on it. So Bob Hansen is now the director of the Office of Drug Control Policy at the state level. He is actually still with Marshall Health. They now run that policy or that center through us, and Brian Gallagher is the counsel, and some of us are on that council in different collaboration parts of it. There was a recent AFA request for funding that came out of that office that's due in like 2 weeks. And one of the things that they're talking about increasing access to is PROACT. It's a MAT expansion grant. And so it's just going to take time. Right now we know that Charleston's sort of the next one. And then it's probably going to be a hub and spoke model. How do we release some of those services down, whether it's through telehealth or telebehavioral health, or set up small centers that aren't nearly the scope of something like PROACT. But most of the time when we're working on this, and our collaboration, I work very closely with W.Va and their Office of Addiction Sciences. We're working to try and identify where there's gaps and where we can fill in some of these with any of these funding resources. So there's talk of Clendenin, there's talk of Boone, we're working with them. Southern Coalfields, we're working on a full strategic plan for the 5 southern counties, and then WV sort of takes over that side. And so it's just time, unfortunately. So it took, from PROACT to conception, it took about 2 years and a good amount of money. The hospitals set that up. They invested in it. And so you have to get that community-based buy-in. But now we've seen it successful. It is a replicatable model. The CDC was here, the Surgeon General, all of those folks are interested in seeing how we can replicate that. The MOMS program, just so that folks know, if someone is in the hospital and they are not quote-unquote caught, I hate, there's no good language, but captured or identified while pregnant, and they just show up and they deliver, and the infant's experiencing withdrawals, and mom needs treatment, she can engage in our MOMS program, which is on the same floor as the NTU, reducing all of the barriers, right? Visit your baby, come to group, go back to your therapist, go visit your baby. And then the social workers can advocate for mom in those settings. And so that's our MOMS program, which again, a MAT program, but located in the hospital. And then what does residential treatment mean, right? So it's the highest level of care. You need to be able to prove that you are not quote unquote thriving in the community, and you need to be offered higher access. So common barriers or costs, really committing to that program, rarely allow children, very few programs allow that, and then a lack of that sort of systemic treatment are issues. What does it mean to have sober living? Varies. That is, we don't know. I'll be completely honest. What does sober living mean in West Virginia? Depends on the house, depends on the day. We have wonderful programs that are highly regulated, have people there, but sober living is not a treatment. It is a house in which people are asked to remain sober to reside. And some of them prey on people, I'll be absolutely honest. Some of them take advantage of situations, they ask people to pay copious amounts of money, and they meet no fire or health or safety codes. Other programs, very well structured, completely, I'd put my best friend in. And so getting to know your community and getting to know those programs is really important before you just sort of make referrals. These are especially dangerous outside of our state. So certain states, again, are having pending lawsuits around this because they set up these sober living homes and all they do is drug test people 3 times a day, definitely not necessary, and they bill for that. And so that's a highly reimbursable experience, and so that is how some of these have preyed on individuals and unfortunately led to death and lack of recovery. What is Project Hope? So I've mentioned this quite a few times because it takes up all of my brain power right now. So Project Hope opened on December 26th because why wait for the holidays when people are homeless and have kids? And if you've met our moms, we wanted to move them in. It's 18 apartments, 2 or 3 bedroom apartments, and we provided 24/7 comprehensive care. ASAM 3.5, that means it's one of the highest levels of residential care, so you have to qualify for that. You can't just be unemployed or not have a house and qualify. You need to, unfortunately, be using substances, not be successfully engaging out in the community. A higher level of care could be needed. For example, our moms who are in that program who continued not to do well were perfect candidates for that. And we can't take severe medical or psychiatric conditions, right? So we are not a locked facility, and we do not have 24-hour psychiatric staffing. So referrals to that program have opened and are starting. We are holding for a little while with our first 8 families because everybody moved in and had a baby, literally. So we had all these women who were pregnant, who moved in, who were in high levels of crisis, and literally I think that we'll have to do some research on that, but within almost 48 hours, lots of our moms went into labor and now have these adorable, very healthy and cute babies. But it's a lot to manage because we have toddlers running around and they're all sick. So I got the flu after one coughed in my face at the doctor's office, and I went to the doctor, can I drink the hand sanitizer? And he was like, no, you're done for. I was like, thanks. And yes, I ended up with it after him. So when he had a positive flu test, I knew what I had to. So those are, that's another treatment program that exists. One of the biggest resources we do make people aware of, and if you don't know about it, is Help for W.Va. This has been an ongoing effort within the state. It is person dependent again. It's very successful. We love referring to it, but it ebbs and flows. It ebbs and flows because of the information they're given by providers, and sometimes just some of the folks that you might get. It's a 24/7, 365 hotline. So you can call day or night, you can text them, and you can chat on their website. And so you can access them at 265, 365. They didn't pick 100 days to quit. I don't know why, I just can't type. Yeah, that's fine. Okay. So yeah, they are all the time. So ignore the 265. They're 365 days a year. And you can call, text, and you can be a provider who calls them. You can be a person who is a family member, a community member, or an individual who needs help. And they will try and connect you to services. Also in Huntington, you can call our quick response team. They'll try and figure out how to connect you to services or make a house call. And we are setting up quick response teams in different places around the state. And now, if you're in Castle County, you can just walk in the doors of ProAct. That currently is business hours. It will slowly expand to evenings, and then it will expand to weekends. Again, we're walking, or we're crawling before we walk, before we run, to make sure that these are providing the highest level of care, because every day is a different day in any of those agencies or programs, and it's very hard to predict or see what we're going to deal with. We are working on some online repositories of all of these educational resources and materials, and training opportunities and programs. Give me about a year, and we'll have all of that up and live around the state. So there's things coming, and if you're in a county that wants to come see or hear about any of these programs, we love to do that. We bring people in, you can come tour ProAct. We just don't do it on the big clinical days where the MAT services are provided. We're maintaining HIPAA, obviously. But if you wanted to know more about them or come and learn just about our programs, we're happy to do that. We set up panels and experiences all around to share some of those successes that are happening there, and then all across the state. Because together we can make a difference, and we're not going to take the stigma of Appalachia any longer. And so we like to say, instead of the city of the epidemic, which is what they called us for a little while, we're the city of solutions at this point. So rebranding that, taking away that stigma that people have placed on us. So that is, normally my contact information comes up after that. It did not, and for that I apologize, but I might be able to very quickly adjust that. Oh, here, I'll start it brand new. So this is my contact. Jeez Louise. Okay, that's my contact information. I'm going to give you my cell phone because, as you can see, I'm just about never at my desk. And then this is my email address. Notice there are 3 L's right there. So that is accurate. It is my last name plus my first initial, OCONNELLL. Thank you, IT department. Next year I'm hoping they can make one of them a 1 or make the 0 an O or just really mess people up. But so my last name plus my first initial, so 3 L's at marshall.edu. If you send it to o'connell@marshall.edu, it literally goes nowhere. So if you don't get a bounce, it doesn't get forwarded to me. That person just doesn't exist. So why couldn't I have had that email address? So feel free to contact me or give me an email, because that'll be the easiest way to see me. And with that, I'll just leave that up there so you can see it. And I think we have, yep. Oh, questions. Okay. I think you asked as we were going, but feel free to ask any other questions that might have come up. Everybody wants lunch.
They help W.Va, whatever it was.
Help for W.Va?
Yes. As say as an attorney and guardian life for a child, all that kind of technical resources might be available in there.
Yes. Yes. So anybody can call. Like I can call and be like, what have you got going on here? The biggest thing that they do a good job of is especially tracking beds around the state, so where there's residential or withdrawal management possibilities, because we do know that unfortunately, if someone says, I need help right now, we're looking at the next 48 to 72 hours of withdrawal. So what are we going to do? And for example, you can't come to Project Open Withdrawal. That would not meet medical criteria. So I need you, especially if you're pregnant, you have to go to the hospital and withdraw there under that managed program. But they keep a good track of that, so they would know that information and can make those connections. Other questions? That was, can anybody call Help for W.Va? Yes. Anybody want? And other states have similar hotlines, like Ohio is 211, and there's other connections depending on where you are, obviously, in the state.
She went through very quickly about the medically assisted treatment and the drugs and what they do. Did you guys fully catch everything that she was saying about the fact that that these drugs prohibit you from using heroin and getting high? Or
they don't prohibit you from using heroin. You can
right,
still
but you don't get
heroin.
the effects.
You don't get the effect.
And also, my question, because you said that they can get it under their skin.
Yes.
And that some of it is like little Listerine type things. Is this in an effort, this under the skin stuff, to stop some of the abuses?
Diversion.
Diversions. So that might be something that where some of you all are worried about one thing becoming just a new addiction, is that idea of the thing under their
The injectable or the implant. So both of those are options that are going to, we'll just see. Unfortunately, some folks with substance use disorders have high levels of fear and anxiety around medical procedures, as some people without substance use disorders do, right? Like, I'm not super fond of going to the doctor. Now I work in one. And so, that process isn't always comfortable. So hearing people out is also important. Like, plenty of folks, you're like, why do you want to go do this? This is obvious. I get the shot. And they are anxious. Like, well, I don't want to be around needles. Like, and they might be using needles. But that sort of process of engaging in that healthcare setting causes anxiety. Similarly, that stigma that they might face, is that nurse going to be mean to me? Is that doctor going to be rude? How can we advocate for people so that they know that they can get safe access? That's a huge part of what we've been doing, is advocating for clients. And then also talking through those concerns, just as we would about any process, right? Like, what are you afraid of, and how can we get some more information for you so that you are less anxious about this process? Yes.
What medications are available with the implant?
So they all have brand names, and so it's basically buprenorphine.
And you have Vivitrol. And you have the Vivitrol.
Vivitrol is the shot.
Right. So you're saying that Suboxone now is an implant?
Yes. Yep. It has a different name. It's It's gone. I can pull it up. Yeah, there's actually another one coming on the market. There's 2 or 3 new Suboxone. Let me see. Yes. So Suboxone, the new implant is going to be it's pro-butene. Pro-butene is the brand name sort of around it, and it is the implant, and it is the new. It's buprenorphine implanted into the body. So it's a slow release that is tricking the brain into thinking that something has landed on the receptor. So rather than the strip going below their tongue, that then releases the chemical into the body, proceeds through the bloodstream, and then goes to the brain, passes through the blood-brain barrier into the brain. It's going to connect with that receptor and tell the brain, you already have that, you don't need anything else. Dopamine is here, and you can start producing that naturally.
And who administers that?
It has to come from a medical provider. So, and who can administer Suboxone or anything like that? For a provider to prescribe medication-assisted treatment, it can be done by a physician or a nurse practitioner, what they call mid-levels. So a nurse prac can be trained to do it. Their training is longer than a provider. They have over 20 hours of training. A provider receives 8 hours of training for medication-assisted treatment prescribing. I will point out there is no other drug required to have a training to prescribe, right? You don't have to go to get 8 hours of training to prescribe opioid painkillers. And so although it's important that our physicians know about it and get to know those other components, it is currently perceived as a barrier. We're going to roll out a huge incentive soon to get them trained on that, and especially through one-on-one trainings where we can do what's called academic detailing, where you bring in a provider who does it really well, they meet with the person and go through that whole process with them. But yes, it can only be done by those folks who are trained, then waiver, and then they have to get a DEA X code, which means they are authorized to prescribe that substance, buprenorphine, Suboxone, Vivitrol, methadone. Methadone, I didn't say, is a daily dose. You have to go daily and collect your dose. So Huntington Comprehensive Treatment Center, Charleston Comprehensive Treatment Center, those are methadone programs. You go every morning. You often line up, which promotes, unfortunately, community stigma when they see everyone lined up outside the Huntington Comprehensive Treatment Program. They line up and they receive methadone. They drink it on the spot. It's pink liquid, and they drink that, and that is their daily dose. They have to come back the next day and get dosed with methadone, and the next day and get dosed with methadone. And so just to think about some of those barriers to that: A, transportation; B, might be hard to make to work on time; C, the snow, right? So Charleston Comprehensive Treatment Center is at the top of that mountain over there. And like I used to be like, I don't know how to get up there. And so those are some of those barriers to accessing that daily. And then they would start to go through withdrawals approximately 32 hours after that dose. So the methadone would wear off. Again, that differs genetically.
How many of you all, because I'm sitting here and this is the first time I've heard that this is the way that it's administered, that you walk in, you drink it, and you walk out. I was under the impression, because we talk about all this misuse of it, that these people were lining up every day because they had got some prescription and they were selling this and that, and giving it to everybody else. How many of you guys have that same thought? Because every time I think of a methadone clinic, I have a negative thought in my head about it. How many of you all have that same thought? How many of you all realize that they're drinking it and walking out so they can't be giving it to everybody else? How many of y'all knew that?
That would be the control. That's a good program, right? So that's, someone's going to go in there and get Huntington Comprehensive, Charleston Comprehensive. Those are the way those programs are maintained.
But is that that's not every clinic, is it?
So the state of West Virginia did a large crackdown on the feds did a large crackdown, and the state specifically, on prescribing of medication-assisted treatment and types of clinics that could dose or allow methadone or Suboxone or Subutex to be prescribed. There was a problem, especially I worked in the MAC field clinically 4 years ago in West Virginia, around the corner. And at that time, a large number of physicians could prescribe based on a cash base only. So you had to go in, provide cash, and they would give you a prescription. So it wasn't tracked by Medicaid, Medicare, or insurance, which is the big stop and block to that. West Virginia discontinued cash-based prescribing in most cases. Again, not all, because there is a need for individuals in certain workplaces that their insurance would then inform their employer potentially of the drug or medication they were on. Certain high-profile clients especially want to pay cash rather than go through insurance, because then it doesn't have to be a diagnosed code, and there are future things when it comes to life insurance, for example. There's all these issues around that. But as about 4 years ago, they put a huge stop to changing this. And 2 years ago, they dramatically changed the laws and tightened up most prescribing when it comes to this, to really eradicate some of that cash-based opportunity and the selling of prescriptions, or similarly, those were people who were handing out like 90 oxycodone or Oxycontin and a Suboxone prescription. And so that sort of drug trade was going on, where people were then trading and selling those drugs on the street for that. And so some of those people are in felony charges, incarcerated. One of them was living on an island in, I forget where she fled to. Yeah, she fled down to an island, so they can't get her. But there's a whole group that sort of did that. And 4 years ago, the number of people who showed up begging for like legitimate medication-assisted treatment went through the roof, because they'd all been cut off of sort of either opioid prescribing programs or similarly illegitimate MAT programs. So like for our physicians at Cabell Huntington, it is almost impossible now for them to prescribe medication-assisted treatment, because they've regulated it, and that's something that if you listen to the legislature today, or yesterday and the day before, they were talking about is when do the regulations become too prohibitive now that we've made it very hard for a primary care doctor to even prescribe. There was an op-ed in the Charleston paper like 2 months ago about that from a physician.
This seems like a really obvious question to me, but why don't they institute similar kind of requirements for giving out the stuff people have the addiction issues with to start with?
Honestly, I mean, off the record, not clearly I'm on the microphone. Lobbying the families that back the significant amount of money that's made on Oxycontin and Oxycodone. I mean, Purdue Pharma is under mass scrutiny right now. Lawsuits coming out of left, right, and central, and still support regularly on camera this is not a problem, and we are not responsible for this issue. So it's a constant sort of pass the buck who's responsible, right? There were a group of physicians who knew absolutely nothing about what they were prescribing and cannot be held responsible, really thought this drug is abuse resistant. It was branded the miracle drug, right? If I'm a healthcare professional and I think I've just been given a miracle, I'm going to give it out to people who are crying and writhing in pain, right? So there's that group. There's a whole other group who went, ooh, quick buck, right? And saw it and overprescribed it out the wazoo. And the minute MAT came along, got that license waiver, or no waiver at the time, and started prescribing that out the wazoo. And we had a whole run of them on the 64 corridor. I had plenty of patients come in residential program and say they all were the same doctor. They'd be like, oh, you used to see you in the waiting room, right? They'd get 120 Oxycontin a week. And so when that kind of prescribing happens, it really floods those types of markets. And those were all, that was a neurologist, even a cardiologist before that. So different factors depend how we can regulate it. And we don't want to, right? Like we need to be able to train and educate people so they're prescribing effectively, but then that we're providing an effective course of treatment. Because if you looked at that chart, when the prescription rates dropped off, we saw increased rates of the synthetics. Why? Because you're addicted to an opioid, now you can't get it. What are you going to do? You're going to move to the next easiest thing, heroin.
Well, thank you very much. This has been very informative, and maybe